The controversy is not on the currencies between Modi's and Banerjee's. First of all, let's clear. We need to come to a consensus also for the treatment of hypertension. Hypertension is such a disease that all the doctor, being is an orthopedic surgeon, microbiologist, dermatologist or physicians, they have to treat or see the patient with hypertension. Now, quickly, we need to discuss certain things. Actually, what is hypertension? Many of your patient will say, sir, my kintu prochur hypertension, ekটু এই tension করে ফেলেন. So that is not hypertension. Hypertension is the measurement in scientific measure which we get by sphygmomanometer. The most important thing in when to treat. If you ask somebody that take antihypertensive drug, they say, sir, if I start taking it, I'll be addicted. But why you need to start, you need to know. Very often you have seen your patient who are taking atenolol for hypertension. That is not a drug of choice now. So this is a new concept. And how much the blood pressure should be lower? Should you decrease this too much or average is acceptable? So these are the new things which you must know, and I quickly come to your point. This is the epidemiology data. Now, what is the problem of inadequacy of hypertension? The most important thing is the patient education, and that is patient's problem. And our problem is we fail to select the right drug. We give you some case example where you will be able to know that where is the problem in picking up, choosing the right medicine in right perspective, and self-medication of the patient. More importantly, patient can take some indigenous medicines. We'll discuss this thing very quickly. So what is the generally acceptable blood pressure regime? Let's see some history. In 1937, the founder of American Heart Association, Paul Dudley White, he said that don't pamper with the blood pressure. Hypertension is a natural tendency of the aging process. So that was a myth. The reality is that you need to decrease it. Now, this is the so-called a difficult copybook definition of high blood pressure. Normal 122, 129, high normal 132, 139, then grade 1, 2, 3, 4. But do you need to read or remember this definition in your day-to-day practice? No. What you need to know is any systolic blood pressure more than 140 or diastolic blood pressure more than 90 has to be defined as hypertension, and it has to be in 2 or more occasions. And remember the measurement of blood pressure technique. It has to be in quiet position, in sitting posture, and not with so conventional stethoscope and sphygmomanometer anymore. It has to be an automated blood pressure in absence of any medical personnel. And make it sure that you have not consumed caffeine 1 hour prior to your blood pressure measurement. You are not anxious, you are not having an immediate urge of evacuating your bowel or bladder. These are the most, and you are not intoxicated. So these are the basal condition, and if you find this blood pressure persistently in more than 2 occasions, you stamp this patient as antihypertensive and choose the medicine what will suit him. The newer concept of hypertension is the ambulatory blood pressure. And if you see that at night time more than 120 and more than 70 is hypertension. So by this definition, maybe all of us sitting in this room will be hypertensive. So ambulatory blood pressure is not a routine protocol of investigation, but some patients who develop significant side effect with antihypertensive drug, or in patient where you find that the hypertension management is appropriate but the target organ damage is going on. So you need to check the 24 hours blood pressure monitoring, and you need to go for a rigid control. So it's a diagnosis and more rigid control of blood pressure, ambulatory blood pressure is required. So this is a new concept. So there are multiple comparison in the guideline statement of hypertension. So that is the controversy. So what you wanted to do? But most of these people says that if you have more than 160 by 100, start with true drug. If it is more than 140, 90, you can start with one drug. And if somebody is elderly, that is more than 80 years, you can accept 140/90, start if it is more than 150/90. Now, you need to treat the patient more aggressively where there is a evidence of target organ damage. So this is called the concept of hypertension plus. So when you see a patient of hypertension, please try to find out what target organ damage or TOD this patient is having. Whether the patient has left ventricular hypertrophy, increased carotid intimal thickness, or decreased ankle brachial index, that means peripheral vascular disease, which is common in patient with hypertension, dyslipidemia, diabetes, and habit of smoking. And not the extensive renal disease where the patient is dialysis dependent. You need to pick up the patient where there is a leaky urine protein in the urine. So you need to pick up the patient who have a albuminuria. So with this thing, you need to see that lower is the blood pressure, lower is the better. So you need to keep your blood pressure below 140, particularly if the patient has diabetes CKD, you have to keep it as low as possible. So this is accordingly JNC 8 or ASH or European guideline. Everybody says the same thing. Now, we need to see how you are going to treat the patient with hypertension. Remember, the concept of non-pharmacological and pharmacological management has gone. So both has to come simultaneously. If somebody has a 140/90 blood pressure persistently, you need to give drug. At the same time, you need to teach the patient that decrease your tummy, decrease your salt intake, and increase your exercise. And this is the JNC 8, that means Joint National Committee of Hypertension 8, which we actually agree all of the medical fraternity of across the world that this should be followed, where we say that if BRAC patient, you start with calcium channel blocker or diuretic C or D, and probably angiotensin receptor blocker or angiotensin converting enzyme in all, but not the beta blocker in everybody. So let's see the evolution of antihypertensive drug, what we have presently with us. From 1940s, the ganglion blocker is rarely being used, but we more often use diuretic. So there is one diuretic, that is hydrochlorothiazide, which was being used, but last few years we are using more thiazide-like diuretic, that is chlorthalidone. What is the difference? Let's see in the next slide. Apart from that, we have alpha blocker, calcium channel blocker, ARBs, and renin antagonist, which is recent, but it has shown a flop show because it has shown an increased adverse event, so it is no more used nowadays. So medicine to treat hypertension, remember A, C, and D, not the beta blocker only. So what is diuretic? Diuretic means it increases the urine output or increases the salt excretion. And they can act in various ways, but the one which we are going to talk about, the thiazide diuretic, they do work in distal convoluted tubule. So don't use loop diuretic like furosemide and torsemide as a first line of treatment for hypertension, because they will increase more salt water imbalance, make the patient more weak. But you have to use in some patient where your kidney function is compromised. Have a quick look into this chart which came in New England Journal of Medicine 3 years back. So what this shows that if you are using chlorthalidone, the bioavailability is better, the half-life is prolonged. So many of our patients who fail to take the antihypertensive drug regularly or miss the drug, maybe chlorthalidone will be a better option. Similarly, metolazone or indapamide also are good, but they are also costly. So thiazide-like diuretic actually works for more than 24 hours, almost in all of the cases. Next important is this molecule, you all know, angiotensin inhibitors or receptor blocker. What is the pattern of uses of this drug across the world? Now, if you see in all the countries, they start either ACE inhibitor, ARB, or calcium channel blocker along with diuretic. Beta blocker in Japan and Canada and US, it is in the lower category, and in European country, they use still some of the beta blocker. So let's take a patient now, that how you are going to treat this patient. This is a lady who is not very obese, but has diabetes, who has chronic kidney disease with a GFR 39. So creatinine is 1.5. Remember, when you practice, calculate the glomerular filtration rate or eGFR rather than serum creatinine only. Because serum creatinine at a 80-year-old 30 kg body weight person, 1.5 creatinine means very low GFR. On the other way around, if somebody has a 80 kg body weight and he is 30 years old only and his creatinine is 1.5, it is normal almost. So you need to see the GFR, and you have a smartphone where you calculate the GFR very quickly. So this patient, despite on chlorthalidone and amlodipine and metoprolol, he is having class 3 dyspnea, and you cannot control his blood pressure. And he has osteoarthritis. So why the blood pressure was not controlled? Because this patient was taking non-steroidal anti-inflammatory drug for osteoarthritis. This patient was having nasal stuffiness, he was taking regular zyclometazoline, and she has an endometrial bleed and somebody has suggested a steroid for her. All this has produced a problem. So it was found that she has endometrial carcinoma, it was operated. She was being put on furosemide, split dose, because chlorthalidone at a GFR of 39 was not working. It will work up to 45. So blood pressure with this two manipulation, keeping the amlodipine and metoprolol, brought down his blood pressure, her blood pressure to normal. But what was missing in this patient is ARB. Can you give ARB in this patient? You should give ARB, but with a caution that potassium doesn't increase and creatinine doesn't increase. This is a patient who has a history of thalamic bleed 3 years back. That means he has a target organ damage. He is a young patient. His blood pressure remains uncontrolled, and there is a evidence of left ventricular hypertrophy in the ECG. So this patient need to be aggressively treated. What he has? There is no kidney issues, no polycystic kidney disease, no renal parenchymal disease, no renal artery stenosis. He is in good medical management, and the moment he wanted to add something more, he says he feels extremely weak and he doesn't take the medicine. And if this patient doesn't take the medicine, he will have another cerebral bleed or he will lose his kidney because of benign nephrosclerosis. So you need to treat him aggressively. So what was done? We changed the beta blocker. He said, okay, my weakness is less. And keep one thing in the reports. The potassium was persistently low. So this gives you a clue that this patient may be having a hyperaldosteronism. All hyperaldosteronism may not be a pheochromocytoma, may not be a significant tumor which will be detected by imaging. So 10% of the Indian population can have hyperaldosteronism, which only may be detected by addition of aldosterone antagonist. And what happened in this patient, that we added spironolactone and his blood pressure just came down to normal, and we kept amlodipine, telmisartan, and a very low dose of selective beta blocker. The last lady is not uncommon, mild hypertension, but don't forget to check the blood pressure in both the hand, and don't miss this thing. This is uncommon but a treatable condition. So this patient has a coarctation of aorta. So we did a coarctation stenting, and only propranolol she is taking for headache, and aspirin she will take for 6 months for this stent. The last case is a very difficult case. A common patient, 68-year-old gentleman, hypothyroid, permanent atrial fibrillation, arthritis, severe renal disease, hospitalization due to hypernatremia, cannot give diuretic. And if you don't give diuretic, he is getting leg edema and pigmentation. And this is the BP fluctuation. So this patient is more prone to get stroke also. That means his Chadver score is very high. Some people who are practicing medicine knows this score. So this patient is on newer anticoagulant, clonidine, telmisartan, allopurinol, and furosemide. He takes of his own. When the BP increases, the more he takes, he gets a hyponatremia. So what we do? I added amlodipine despite having significant edema. And I asked him to put elastic stocking. So his edema is a little bit controlled. He says when I open it at the end of the night, the leg is fine, but it becomes swollen. In the morning, it again becomes normal. So we accepted one side effect, that is edema. But this patient blood pressure could be controlled adequately. So the most important thing is, if the blood pressure cannot be controlled with this medicine, what we can give? A renal denervation therapy. Unfortunately, this is still under investigation still, and we are not getting a very good encouraging result still now. Now, the most important and last topic what I am going to discuss is how much lower is the blood pressure. Until and unless the patient is very elderly, lower the better. So with this concept, two studies you need to remember. One is Accord BP study, which is a study for patient with diabetes to see whether you controlling the blood pressure more aggressively is in accordance with a decreased target organ damage or MACE or not in future. So what it has been shown in Accord BP study, that if you lower the blood pressure below 120, there is no benefit. InBase study also showed the same thing. And the latest sprint trial, which came in last year, they gave a marvelous result. That if you have an intensive blood pressure goal of less than 120 rather than 140, your chances of stroke, heart failure, and death is less. So, at the cost of more syncope, injurious fall, and bradycardia, and electrolyte imbalance. So what we do? Should we ask our patient to keep our blood pressure as low as possible, or accept 140/90 below that, or below 120? The controversy is still on. For our population who are very sensitive to the medicine, who are more concerned about low blood pressure rather than high blood pressure, we are not going to follow sprint trial. We wanted to control them optimally, but if the patient volunteers and he has a evidence of target organ damage, try to control as low as possible, maybe up to 120/80. But remember, they should not suffer from recurrent syncope, hypotension, or organ perfusion. So with this, I end my talk, and it will be nice to take any one of your, I think I just take the last one. So in a patient with hypertension, do lifestyle modification. Initial one, either you start with a thiazide diuretic ACE inhibitor or ARB, beta blocker, calcium channel blocker. The important thing is, if the patient is diabetic, try to give ACE inhibitor or ARB. If the patient is having heart failure with a poor ejection fraction or a history of previous myocardial infarction, try to give beta blocker, but not atenolol, either metoprolol, bisoprolol, or carvedilol. So that's how the treatment of hypertension has become easy. We are not supposed to give clonidine, Minipress XL, Prazopress XL until and unless the blood pressure is not controlled with A, B, C, D. Thank you.
Expert insight. Now the session is open for question and answer. So if you have any question for the sir, you can ask.
Yeah. Joint is dependent. Sir, please bolun.
So you have not touched cilnidipine. What is your opinion?
I have not touched cilnidipine, I have not touched azelaisertan. So the thing is, cilnidipine is supposed to produce less edema than amlodipine. And it's probably more friendly for the nephrologist because they says that it decreases the proteinuria. Amlodipine increases the proteinuria. The problem is that for all practical purpose, we follow the guideline what the European and American says. So cilnidipine still is not there as a first line of management. Among the calcium channel blocker, amlodipine only they are encouraging. But my experience with cilnidipine is good, and particularly in patients develop amlodipine related edema, definitely we can give cilnidipine. The dose beyond 20 milligram is not effective. So remember this thing also. Now there will be a sea changes in newer trial will be coming probably that will be giving more highlight on these issues. And it does not produce reflex tachycardia like amlodipine. So that's a good thing, but no outcome benefit has been shown. Maybe one of the fact that it became a Japanese molecule, so there is no Japanese conference still now happening, so we'll be able to know what is exactly the scenario with cilnidipine. Actually certain. I'm not used till now, so I can't tell you. My impression is the most potent ARB is valsartan. My opinion. But that is exclusively should be used for patient with heart failure. Yes?
Question?
Sir, salt is restricted into hypertension patient. So how much salt should be restricted for hypertensive patient as compared to a normal adult, healthy adult? What is the amount?
See, the thing is that there is a study which is called PURE study, which actually addresses these issues that those who are hypertensive, they are excreting less salt in their kidney and losing more potassium. So that is a study by Selim Yusuf. So what it means indicate that if you take more fruit, you retain more potassium. So in absence of kidney disease, you should increase more intake of fruit and vegetable. So far as the intake of salt is concerned, traditionally, if a patient want to prevent hypertension, he should take less than 5 gram. Now, if somebody has a stamped hypertension and you find that the patient blood pressure cannot be controlled and the hyponatremia is not there despite diuretic, 3 gram is fine. So we are not going to discuss about 3 gram and 5 gram because average Indian patient, particularly those who are in this part of the country, consume around 10 gram, I think, maybe more than that in some people. So that's a real problem. And the problem is that if you invite somebody and if you don't give salt in the food, they feel insulted. তাই না আমাদের সিস্টেমে এমনই আছে যে খাবারে নুন না দেওয়াটা একটা অপমান কি খেতে দিয়েছে ওদের নুন নেই সো 3 gram in the maximum and 5 gram is best and the patient if have heart failure it has to be less than 3 gram but there are some people who develop frequent hyponatremia for them the traditional teaching is you give them for some time allow them free salt intake for some time and then make it plateau rather than encouraging to give a high salt intake for the most of the time.